Hello everyone. Very good evening to all of you and welcome to the Unacademy YouTube live session. So today we are going to discuss about autoimmune disorder, where I will be discussing about the SLE, right? So today we will be discussing about the SLE, and the basic highlight of the SLE is to teach you about that immunofluorescence pattern which examiner ask in exam, which I have seen trending in last 2 years, right? In AIIMS exam also they had asked question, and then in All India also there was some question, right? So this will be definitely helpful for you. And basic idea is to discuss that immunofluorescence microscopy and to teach you in proper way, right? So let's start with the prayer that you all should have a great and grand success in every exams of your life and stay healthy, safe and strong in this pandemic. Very good evening to all of you, Dr. Imran, Dr. Manish, Shubhanil, Sagar, Priyadarshini, Devashish, Laganji, Dhirendra Singh Rathore, first year student. Very good, very nice. Right, so that's good, great initiative, because first year we never knew that we are going to discuss or we are going to learn like this. First year we used to go for movies and all, right? That's great. Very good evening to all of you. Very good evening. So let's start. And first I will tell you about this thing. When you come to the Unacademy platform, right? So this is my profile, Unacademy profile, where you can follow me, this highlighted area. And here at this profile you can regularly see that I am conducting a lecture at regular interval at 9 p.m. sharp. So these are the special live lectures. Remember, these are the special live lectures. So these are the special live lectures which is free, right? So these are the live lecture which are the free live lecture, anybody can attend, right? So you all can attend, like you are attending here YouTube live session, right? So that is also one option. You can attend my lecture, you can learn the MCQs, various tricks and tips, right? And for that you have to follow my profile at Unacademy, so that whenever I'm putting any lecture you will be notified. And if you follow my Unacademy profile, you can see my all lectures which I have taken earlier, which will be extremely helpful for your exam, as I have seen that many questions came in AIIMS, FMG and all exams, right? So please do follow this profile and see all the lectures, not following the profile, right? See the lectures which I have taken, which are free lectures, which you can see. There are numerous, so many lectures I have taken, so you can see there, and you will definitely having benefit. I have taken so many lectures where I have taken lecture of the Robbins 10th edition update also, like autoimmune disorder, right? Like genetics, all these things I have taken. Like recently I have taken leukemia, lymphomas, right? Anemias, bleeding disorder. So all these things you can see, and you can have an immense benefit from that thing. That is the beauty of the Unacademy. So now this is the iconic subscription of the Unacademy plus prep ladder, right? So this iconic subscription also you can subscribe, and you can have a benefit of that thing. What is that benefit? You will be getting the benefit of the live lecture of the Unacademy and the recorded lecture of the prep ladder, right? So both are together, and you can see the subscription and you can have a advantage in that thing also, right? So that will be a very good thing. This iconic subscription, you can see various plans, right? So if you look at the plans, this 12 months, 18 months, 24 months and 36 months. So these are all the plans where you will be getting both the app, right? So you can use both of them, and if you are going to subscribe any of them, you can use my name as a code, that is the Dr. Devesh 10. If you are subscribing, you can use my name as a code and you will be getting discount without any gap, Dr. Devesh 10, right? So these are the subscription, and you can see the prices against them. If you are subscribing, you will be getting the discount of the 10%, right? That is the one great advantage, right? So on the plus courses of the Unacademy, where we are conducting so many classes, right? Live classes, there are live tests and quizzes, batch courses, and there are so many structured schedule. And in upcoming session you are going to see many structured session which will be very helpful for all the aspirants. So you can see all these 1 month, 3 months, 6 month, 1 year and 1.5 year of the subscription, right? And you can subscribe, and the same thing will be applicable if you are using my name, Dr. Devesh 10. If you are using my name, Dr. Devesh 10, you will be getting discount for the 10%, right? This is the daily. You have to upload the Unacademy Unacademy app at your mobile, and then after the Unacademy app you will upload, then you will go to the NEET PG section. In NEET PG section, every day at 8 p.m. there is a live test. Please do attend those tests. Definitely you are going to get advantage in your exam. It's a kind of daily practice, right? So you'll be having daily practice for all these things, right? So let's start. As I have told you, in this session I am going to tell you about the SLE, right? So autoimmune disorder, I have taken one disorder, that is the SLE. Next session I will be taking some other disorder, autoimmune disorder. So here why SLE I have taken, because it's a big one and I have a limited time to discuss. So when we talk about the SLE diagnosis, remember when we talk about the SLE diagnosis, these are the recent criteria. We are using two things, clinical criteria and immunological criteria, right? So we are going to use two criteria, clinical criteria and immunological criteria. So clinical criteria, there are so many things, right? You can go through this table, right? As I have written that skin lesion will be there. So what are the skin lesion? Acute and chronic cutaneous lupus, right? Then oral ulcer or nasal ulcers. There will be alopecia, and remember this alopecia is non-scarring alopecia, right? SLE full form is the systemic lupus erythematosus. Systemic lupus erythematosus, right? I hope you all should be knowing this. Usman Khan, are you in first year, Usman Khan? Or okay, fine. So acute cutaneous, and we were talking about the alopecia. Alopecia means loss of hair, right? This loss of hair will be non-scarring. Non-scarring alopecia will be present in the SLE, right? Then you will see the synovitis, which will be involving two or more joints. Serositis, all the serosal aspect, right? Like pericarditis, right? Pericarditis, pleural aspect, pleuritis, all these inflammation is itis, pericarditis, pleuritis, serositis, right? So that is how we are saying them in a single manner, that is called serositis. Serositis is quite characteristic of the SLE. Renal involvement will be called as lupus nephritis. Renal involvement will be called as lupus nephritis, right? So there is a renal involvement, there is a neurological involvement in the terms of the depression, psychosis, right? Hemolytic anemia will be there. Leukopenia means leukocyte count will be reduced, and that will be less than 4,000 per mm cube, or lymphocyte count will be less than 1,000, right? And then platelet count will be also decreased, which will be less than 1 lakh per mm cube, right? So these are the important points about the diagnostic criteria of the SLE, right? So now you understood. When we are talking about the diagnostic criteria, these are the clinical criteria. You have seen the skin lesion, acute and chronic cutaneous lupus, then oral ulcer, then non-scarring alopecia, synovitis, serositis. So musculoskeletal, see, remember like this, there is the involvement of all the system, starting from the skin to the brain, to the lungs, to the heart, to the kidney, to the musculoskeletal system. Then you are seeing the blood also, right? In the hematology also, right? Hemolytic anemia, leukopenia, all these things. So all these are clinical criteria. All these are clinical criteria. Then come to the immunological criteria. Immunological criteria means there is an antibody involvement. Immunological criteria means antibody. So what kind of antibody you are going to see here? What kind of antibody you can see here is the increased anti-nuclear antibodies, right? Increased anti-nuclear antibodies. Then you will be seeing anti-double stranded DNA antibodies, then anti-Smith antibodies, anti-phospholipid antibodies. Then you will see the complement level will be decreased. You will see that, right? Some of the complement you will see that in our discussion also, that low complement will be there in C3, C4, and this CH50 is the complement test where we do, and the direct Coombs test, because they will be having antibodies, right? So how we are going to diagnose SLE? So for the diagnosis of the SLE, this point you have to remember. More than 4 criteria should be present. More than 4 or more than 4 criteria should be present. And how we are going to choose that? 1 clinical and 1 lab criteria. So there will be 1 clinical criteria from here, 1 clinical criteria and 1 lab criteria. So more than 4 criteria should be present, and out of 4, remember that means that when you are going to see the 4 criteria, out of those 4 criteria, there should be minimum 1 clinical criteria and minimum 1 lab criteria should be present, right? Or there should be a biopsy proven lupus nephritis with anti-nuclear antibodies or anti-double standard. Means that they are saying that if there is a biopsy showing that lupus nephritis, then also you can say that it is a SLE, right? So these are the criteria as I have told you. So just wanted to make a mnemonic, right? This is a very famous mnemonic in the books, right? Various books you will be finding this. To remember the clinical findings of the SLE, that is the MD SOAP brain, right? MD SOAP brain is a mnemonic here. So what is M? M is malar rash, D is discoid rash, S is serositis, O oral ulcers, arthritis, photosensitivity, B for the blood hematological involvement, R for the renal lupus nephritis, anti-nuclear antibodies, immunology means that double stranded DNA and Smith antibodies, and neurology is the CNS involvement, right? So these are the mnemonics, MD SOAP brain. So now you can see MD SOAP and brain. So this will help you to remember MD SOAP brain, right? These initials will remind you how to remember all these features in the SLE patient, right? Now I will show you some of the images, as this is the image based revision. So I will show you, see this is how it will be looking in your dermatology session also. Means when you are going for your dermatology posting, you will be seeing all these patients, right? So see, when you are seeing a rash is along the cheek like this, right? So this is the malar area or malar bone of the face. So when you are seeing this, it looks like a butterfly. If you look at them, it looks like a butterfly, right? It looks like a butterfly. So it is also called as butterfly rash. So malar rash, which is present on the malar bone, also called as butterfly rash, right? Butterfly rash, right? So this is the butterfly rash we are seeing. So malar rash number 1. Then you can see there is something as if some disc is implanted on the skin. This is called discoid rash. This is called discoid rash. Here you can see loss of hair. So this local loss of hair is the present in the scalp area, and this is called alopecia. Alopecia means loss of hair. Alopecia means loss of hair, right? So there is a loss of hair, and as I have told you, there is no scarring. So non-scarring alopecia, right? So non-scarring alopecia. So now you can see in dermatology there are 3 findings we can observe, that malar rash, butterfly like rashes which will be present on the skin, and remember this will be aggravated by sunburn. So this will be increased during the radiation injury, or you can say during the sunburn. So whenever this lady will be going outside, she will be telling that my rashes gets increased when I go to outside in the sunlight, right? Discoid rash, disc-like feature will be present, and discoid rash will be there, right? Alopecia is non-scarring alopecia, right? Now, as I was telling you, the multiple organs are involved. So basically SLE is a multi-organ system, right? Multi-organ system involvement will be present, right? So now you can see all these organs are affected. So I just wanted to let you know that in lungs, what will be the most common finding? Can you tell me in the comment box? These are all MCQs. Lungs, pleural effusion or pleuritis or pleurisy. What will be the most common finding? Can you tell me what will be the most common finding in the SLE lung? So what is the most common finding? Pleuritis, right? So pleuritis is the most common finding in the lung SLE. What is the most common finding in the heart SLE? Can you tell me in heart what is most common? Heart, what is most common? Endocarditis or Libman sac endocarditis or pericarditis? What is most common in the heart? Can you tell me what is most common in the heart? Right, so most common in the heart is the pericarditis. Always remember, most common cardiac manifestation in SLE is pericarditis. So these are all important MCQs, right? Can you tell me what is the most common in the blood? Most common in the blood? What is most common in the blood? See, Libman sac endocarditis is not, not the most common. Libman sac is a characteristic named lesion in the SLE carditis, right? But when examiner is talking about what is most common, this is the line of Harrison also, right? If you read Harrison, you will find the heart involvement. This is the first line, right? They are writing that pericarditis is the most common presentation, right? So when we talk about the blood, remember in blood there are all type of autoimmune, right? Autoimmune granulocytopenia, autoimmune thrombocytopenia, autoimmune hemolytic anemia. So out of these three, most commonly, yes, most commonly it is autoimmune hemolytic anemia, right? So autoimmune hemolytic anemia is most common. Very good. So very nice, very nice. So I'm seeing all your responses, right? Pooja, Prashant, right? Amit, Devashish, Prashant, Priyadarshini, right? Pooja, all are telling autoimmune hemolytic anemia. That's great response, right? In kidney, you will be seeing lupus nephritis. I will be discussing that, right? Lupus nephritis, kidney involvement is called as lupus nephritis. I will be telling you about the lupus nephritis after some time, right? Musculoskeletal system involvement. Can you tell me what kind of arthritis you will see here? Sorry. What kind of arthritis you will see here in the musculoskeletal system? Can you tell me what kind of arthritis? Erosive or non-erosive? Erosive or non-erosive? Right. So here we have to remember they will be having non-erosive arthritis, right? They will be having non-erosive arthritis, right? So SLE patient, when you are seeing musculoskeletal system involvement, there will be no erosion of the joint and there is a non-erosive arthritis, right? So they will be having non-erosive arthritis, right? So yes, very good, Tanya, Harsha, Amit, Devashish, right? So Pooja, all are Prashant, right? So all are telling that it is a non-erosive arthritis. So now you have to understand all these things, right? So what we are seeing here, lung is involvement, lung is most common, pleuritis, heart is pericarditis, blood is autoimmune hemolytic anemia, kidney is lupus nephritis, musculoskeletal system is non-erosive arthritis. Now question is, out of all this system, my question is, out of all this system, which is most commonly affected system, hematological system or musculoskeletal system or kidney or any other organ? Can you tell me out of these things, overall in SLE, which system is most commonly affected? Which system is most commonly affected? Can you tell me? Why examiner asked this question? Because we often study this in kidney, right? So we always feel like that kidney is most commonly affected, but it is not like that. But it, yeah, Prashant is telling musculoskeletal system. So this point is very, very important. See, these are the question which examiner is going to ask you in your exam, right? Always remember musculoskeletal involvement. Musculoskeletal involvement is most commonly affected system in the SLE, which you will find in 95% of the cases. If you go and see the table of Harrison, you will find this wording, right? After 95%, that hematological involvement will be seen in the 85%. So this is the second most common, right? This is the second most common. So please remember, first most common is the musculoskeletal system, right? 95%. Then it is a autoimmune, then there is a hematological involvement, and then there will be a lupus nephritis. So please remember this point. Musculoskeletal involvement is the most common involvement, where you will see the non-erosive arthritis, and the most common presentation is also non-erosive arthritis and arthralgia, right? Clear? So coming to the this image-based picture which examiner can ask you. So if you look at this picture, can you tell me? See, this will not be asked like this. Look at this picture and tell me the answer, right? It will not be asked like this. Examiner will be asking question like this. This is the spleen specimen of the spleen or histopathology of the spleen from the patient who was suffering from the SLE, right? What is your diagnosis? What is your diagnosis, right? So that is how question will be asked, right? What is your diagnosis? Or examiner will be asking you, what is the characteristic named lesion you are seeing here? Or examiner can tell directly that this onion skinning of the spleen is due to, this onion skinning of spleen which you are seeing in SLE is due to. No, it's not Sago spleen, right? See this, in this spleen, if you look at this, this is the small arteriole, and there is a, these are all the, these are all the eosinophilic structure is the area of the fibrosis. This is the area of the fibrosis. See, I'll just recapitulate this thing. This is the arteriole, splenic arteriole. I'm just writing A, splenic arteriole. And around the splenic arteriole, now you can see there is a concentric thickening, concentric fibrosis, right? So this is the fibrotic area. This concentric fibrotic area around the arteriole, this is the arteriole, is the reason for, now you can see they are looking like a onion skin. So that is why it is called as onion skinning or onion skin appearance in the spleen. There are so many onions in the pathology, but this is the, they will not be asking like random thing. They will be giving you history. Patient was having SLE, or they'll be telling that patient was having malar rash. Then there is a discoid rash. She was positive for anti-nuclear antibody. Spleen was resected, and this is the splenic specimen. Most likely it is, right? So most likely it is onion skin appearance. And remember, this onion skin is why? Why this is onion skin? Because of the inflammation, right? Inflammation of what? Inflammation of the arteriole. So what we are going to call them? That is called vasculitis. So onion skin due to the vasculitis. Due to the vasculitis. So now I understood this onion skinning is because of vasculitis. So that point we have to remember that spleen, you will see onion skin lesion in the SLE patient. Spleen onion skinning is seen in SLE patient, and this onion skinning is because of the blood vessel inflammation around the arteriole. Remember, around the arteriole, because of inflammation there will be more fibrosis, and you can see all these are fibrotic area. This entire width I am showing you, this is all fibrosis. You can see that entire width, you can see eosinophilic structure. So these are all fibrotic areas. These are all fibrotic area. So this is the fibrosis around the arteriole. So periarteriolar fibrosis looks like a onion skin, right? So that is why we are calling them as a onion skinning, and this is all because of inflammation. And vessel inflammation is called as vasculitis. That is why I am saying it is a vasculitis which is giving rise to onion skinning appearance, right? Done? Right. So I was telling you lupus nephritis. Right, according to the WHO, lupus nephritis has been given 6 grading, right, which is from the grade 1. You can see from the grade 1, 2, 3, 4, 5 and 6. The uppermost one, the grade 1, will be having best prognosis, right, and the 6 will be having worse prognosis. So we can say that it is in the order of worsening of the prognosis, right? This is given in the order of worsening of the prognosis. So minimal change is the grade 1, mesangial is the grade 2, focal proliferative is grade 3, diffuse proliferative is grade 4, membranous is grade 5, and lupus sclerosing is the grade 6, right? Now basically examiner asks question that which of the following will be having wire loop lesion? Which of the following will be having wire loop lesion? Wire loop lesion, right? So which of the following will be having wire loop lesion? So, and what is wire loop lesion? Can you tell me what is wire loop lesion? First I want to know that what is wire loop lesion. See, this is the glomerular capillary which I am showing you by a simple diagram, right? Glomerular capillary will be looking like this. And below the endothelium, remember this, below the endothelium like this, right, you will see there is a immune complex deposition. Below the endothelium there is a immune complex deposition, right? So this immune complex deposition is below the endothelium. So what kind of deposition it is? Wire loop lesion is due to subendothelial deposition. Subendothelial deposition, right? So subendothelial deposition is the reason for wire loop lesion, right? So I'll just show you a picture also so that you can remember very well. This is the pars staining, right? This is the pars staining. In this pars staining of the glomerular capillary, you can see how are these thickened. Can you see these are the thick line? So all these thick line is the subendothelial collagen deposition, right? These are all subendothelial subendothelial immune complex deposition. So these are all subendothelial immune complex deposition, and this subendothelial immune complex deposition is the reason for the name, because they are looking like a loop. So wire loop lesion, right? So they are called as wire loop lesion. Now you understood. So wire loop lesion is subendothelial immune complex deposition, which will be more prominent on the pass staining, right? So you can see there are so many loops, right? You can see there are so many loop, one loop, second loop, right? So there are so many loops have been formed because of this subendothelial collagen deposition, right? Subendothelial immune complex deposition. Clear? So if we are talking about the wire loop lesion, right? So where you will see wire loop lesion, that was the older question in the PGI exam also, right? So wire loop lesion, you will see wire loop lesion you will find in three, means focal proliferative 3, 4 and 5. Focal proliferative, diffuse proliferative and membranous. So remember, I'm just writing here 3, 4 and 5. Focal proliferative grade 3 or class 3, 4 is diffuse proliferative and 5 is membranous. So all will be having a wire loop lesion, right? So the question is where you will be seeing them most commonly. Lupus nephritis, wire loop lesions are most commonly seen in which of the following? So remember 4, which is also called as diffuse proliferative glomerulonephritis is most commonly associated, right? So they are most commonly associated with the wire loop lesion, right? So most commonly it is grade 4, which is diffuse proliferative, right, which is associated with lupus nephritis, right? Now in this, what we have to understand, see the clinical point of view. When we talk about the clinical points, right, clinical points means now you are working as a nephrologist and your pathologist has given a report, the wire loop lesion of the SLE patient, right? In this SLE patient, in biopsy of the kidney, I am seeing numerous wire loop lesion. So this wire loop lesion is suggestive of what? What is this suggestive of? What you will think of? This is the acute, this is the active disease or dormant disease. This patient will be having good prognosis or bad prognosis. So what is your thinking? What is your opinion? When I am writing a report to you, you are a nephrologist and I am your pathologist. I am writing a report to you that wire loop lesions are seen. Kindly correlate clinically. So what you will think of? Can you tell me in the comment box what you will think of? It is a active disease or dormant disease? Yes, very good, very good. Devashish is telling it's a poor prognosis. Active disease or dormant disease? Very good. So remember, this will be suggestive of, very good, active, and this is the active disease and poor prognosis, right? So that is how question will be asked in exam also, right? So this point you have to keep in mind. Whenever you find wire loop lesion, it means it is a suggestive of active disease and this patient will be having poor prognosis, and as a clinician you have to become more intense for management of these patients, right? So that is why we study and we ask all these questions in the MCQ exam, so that we should be knowing about that. What is the significance of the wire loop lesion? We should not finish up by knowing that they are seen in 3, 4, 5 and most commonly seen in 4. These are the subendothelial complex. So it's nothing of use. What is the most important thing in this is the knowing about the clinical significance. Wire loop lesion, active disease, poor prognosis, more aggressive management should be given to such kind of patient, right? So that is how you have to remember about lupus nephritis. Lupus nephritis, this was the question in the AIIMS exam. What do you mean by full house phenomena? What do you mean by full house phenomena? So full house phenomena means you will see all the antibody, IgG antibody, IgA antibody, IgM antibody. So these three, minimum these three antibodies should be present, IgG, AM. So we can remember that these antibodies, IgG, IgA, IgM, along with these antibodies, there must be a presence of complements like C1q and C3. All these things, when they are present together, this is called as full house phenomena. Full house phenomena, right? Full house phenomena. You can see 3 antibodies GAM, IgG, IgA, IgM, and 2 complements C3 and C1, right? So when you find these 5 things together, they are called as full house phenomena, because this is the what is the clinical significance of the full house phenomena? What is the clinical significance? Again, I'm coming back to this thing, because see, full house phenomena is a immunofluorescence staining, right? This is the immunofluorescence staining, right? And what is clinical significance of this immunofluorescence staining? What is the clinical significance? So remember this point, full house phenomena, we all know that, okay, all antibodies will be there. But what is the clinical significance? Again, I'm coming back to the clinical significance. Clinical significance is when you are seeing full house phenomena, remember, most commonly they are associated with the lupus nephritis. Most commonly they are associated with the lupus nephritis. And which class or which grade? So class 4. Remember, class 4, diffuse proliferative glomerulonephritis, right? And this will be also an indication of the active disease and bad prognosis. This will be also indication of the active disease and bad prognosis. This can be the future question. So that is how question will be framed in the future exam, because NEET and next exam, now examiner is going to ask you the clinical oriented question. They know that full house phenomena, everybody is knowing, GAM, C1, C3 is present, all kind of immune reactant will be present. But the basic question is, what is the clinical significance of all these things? If your pathologist is saying that on immunofluorescence staining there is a full house phenomena, what is the meaning? What do you think of? They are having IgA, M, and C1, C3. That pathologist knows, right? What is the help for the patient? Patient will be having poor prognosis. He is having active disease. That is the point we have to remember for this thing, right? So now you understood. Full house phenomena is associated with lupus nephritis, most commonly seen in type 4, which is diffuse proliferative glomerulonephritis. Can be also a question in exam, right? Done, right? Now in the SLE diagnosis, when we come to the immunofluorescence microscopy and the serology. So serology and immunofluorescence, these are the two things which you employ for the diagnosis of the SLE patient, right? So when we talk about the serology and there are certain questions, right? There are certain questions where you will be asked in exam, and like you will be having controversy also, right? So here I am just going to kill that controversy by telling you what are the questions and what will be the answers for all these questions. What is the most sensitive antibody for SLE? Can you tell me what is the most sensitive? Very good. Anti-nuclear antibody, ANA, right? All these are anti-nuclear antibody, right? All anti-nuclear antibodies, like whatever you study, double stranded, right? Or Smith antibody, all these are the nuclear antibodies. So this is the sensitive test. What is the most specific test? Can you tell me? What is the most specific test? What is the most specific test? What is the most specific test? And anti-double stranded DNA or Smith? So remember, Smith is better than double stranded DNA, right? So this is the question which had been asked so many times in the NEET PG exam. Most specific will be the Smith antibody, right? Most specific will be a Smith antibody. But when we talk about the best for diagnosis and best for prognosis, then your answer will be double-stranded DNA, right? So these are 3 important questions we should always remember. You can say exactly 4 questions, but these 3 points you have to remember. What is most sensitive? Anti-nuclear antibody. Most specific? Smith antibody, because Smith antibody is never seen in any other autoimmune disorder, right? And they are highly specific. Their specificity is approximately 95%, whereas double-stranded DNA is 90% specific, right? So specificity is very high in this Smith antibody, but double-stranded DNA antibody is good for the diagnosis as well as prognosis, right? So this point we have to remember. Why diagnosis it is good? Because double-stranded DNA is specificity and sensitivity both are very high, right? Whereas sensitivity is very low in case of Smith antibody. That is why for diagnosis and prognosis, both ways SLE is best diagnosed by the double stranded DNA. Clear? Done? Now, the immunofluorescence pattern, here I will tell you there are total 5 patterns. Please remember, total 5 pattern of the immunofluorescence which I am going to tell you, right? And these 5 pattern will be, they are not diagnostic, but they are predictive. They will be associated with many of the, antibodies. But what I am going to tell you, the most common associated antibodies to the particular pattern. So 5 pattern, which is the most common antibody, I am going to tell you. I am not saying ki this will be the only antibody which will be seen in this. Please understand this point. I am going to tell you which is most commonly seen in the RIM pattern. RIM can be associated with many antibody. But what is most common? That is the point I am going to discuss now. Right? So RIM or peripheral. So what I am showing you, this is the immunofluorescence, and immunofluorescence pattern. This is the nucleus. All these are nuclei, right? We are applying the fluorescence probe, and then we are applying that fluorescent color, and then we are going to see the antibody reflections, right? And how these antibodies are looking like. Now in this particular case, right, you can see there is a bright yellow green color at the peripheral margins only, right? So that is why it is called as RIM, because they are like a rim, or also called as peripheral type of immunofluorescence, right? So RIM or peripheral pattern of immunofluorescence is seen in. So this is how you can see, this is the nucleus, and this is the immunofluorescence, right? So this is the bright immunofluorescence, peripheral or RIM. Peripheral or RIM pattern of immunofluorescence staining is seen in double-stranded DNA antibodies. So most commonly they are associated with double-stranded. So I'm writing most commonly, right? So I always say that it is most commonly double-stranded DNA antibody, right? So RIM is associated with double-stranded DNA antibody, right? Now the second pattern of immunofluorescence. Now you can see what we are observing here. That entire nucleus is now, they are equally. Previous picture we were seeing that the bright yellow color was at the periphery, but now you can see the bright green color is involving entire nuclei. So this is called diffuse pattern. They are homogeneous pattern. So diffuse or homogeneous, H for homogeneous, remember, H for homogeneous and H for histone antibodies. Antihistone antibodies. So where you will see antihistone antibodies? Can you tell me? Where you will see antihistone antibodies? Where you will find antihistone antibodies in that diffuse or homogeneous immunofluorescence? In which condition you will see? So this will be seen in, yes, very good, drug induced. Yes, always remember, it will be seen in drug induced. Antihistone will be seen in drug-induced lupus erythematosus, right? So this point you should always remember. Antihistone is used for diagnosis of the drug-induced lupus erythematosus, right? So hydralazine or procainamide, these are the drugs which are commonly associated with the drug-induced lupus, right? So clear? So when you find RIM pattern, double-stranded DNA. When you find diffuse or homogeneous pattern, it will be a antihistone antibody. Now coming to the next one. Now look at this one. This is the nucleus. How is the background? Background is green, right? And you can see these are the dark dots. Right? So now the representative nucleus I have drawn here. You can see the nucleus, and you can notice the background color is green, right? As I have told you, background is green. And in this background, green background, you can notice these are the black dots, right? These dark dots are like a specks. So what is this? A speckled pattern of immunofluorescence. These are speckled patterns. Specks are present. So speckled pattern of immunofluorescence. What is a speckled pattern? Background will be green and dark dots will be present against the green background. Speckled pattern, S for speckled, S for Smith antibody. That was the question in one state exam in 2014 and very frequently asked question, right? Speckled pattern, because this is the most common pattern you are going to see. Non-specific pattern, most common non-specific pattern. Remember, this pattern is the most common and non-specific pattern. Most common and non-specific pattern, right? And they are usually associated with the Smith antibodies, right? Smith antibodies, right? Fine. Now second pattern, now you can see this. Now you will see the little bit change in the pattern, right? You can see here what is happening here. Can you notice this nucleus? The background is dark. Can you see this? Background is dark. Background is dark, and you can notice there are so many green dots, right? There are so many green dots. And how are these green dots? Can you see them? They are small, very small. That is why they are irregular. You cannot see their boundaries, and they are numerous. Small, irregular, numerous. Remember, small, irregular, numerous. When you find this corresponds to the centromere. Remember, this green dot, which is small, irregular, and numerous, they will be corresponding to the centromere of the nuclei, right? And that is why it is called as centromeric pattern, right? Centromeric pattern. Where you will see centromeric pattern? Can you tell me where you will see centromeric pattern? Centromeric pattern is commonly seen in the scleroderma, right? It will be commonly seen in scleroderma. This was the question in All India exam 2016. This diagram was given in All India exam 2016. It's scleroderma. They have given this picture. They have given this picture, and they had asked this question that what will be the most common cause of death in this patient. The patient was having this kind of particular immunofluorescence staining of the antibody. What will be the most common cause of death? So what is the most common cause of death in a scleroderma patient? What is the most common cause of death in a scleroderma patient? Can you tell me? Most common cause of death in scleroderma patient is pulmonary involvement, right? Pulmonary involvement, which will be leading to the fibrosis and hypertension, right? So now understood. So this point we have to remember that most common cause of death in scleroderma is the pulmonary involvement, right? So that is how you have to identify centromeric pattern. So always remember, centromeric pattern is background will be dark. Background will be dark. There will be green dots, and these green dots will be small, irregular, numerous. Now look at this one. If you compare to the speckle pattern, what was the speckle pattern? Can you see this? Speckle pattern background is green. Speckle pattern background is green. Centromeric pattern background is dark. Now you understood the difference. Speckle pattern in speckle pattern you can see background is green and there are dark dots. Here it is opposite. Here it is opposite. You can see centromeric pattern background is dark and green dots are present. And how is the green dots? Small, irregular, numerous, corresponding to the centromere. Now look at the nucleolar pattern, which was the AIIMS question in 2017-18, right? Nucleolar pattern. How will be the appearance? Can you see the nucleus? Can you see the nucleus? How is the background? Background is dark. And how is the green dots? How are the green dots? Can you see the green dots were present in the centromere also? Now understood, green dots are present in centromere also and nucleus also. But centromere will be very small. That is why they are very small, irregular, numerous. But nucleoli will be very few, 2 to 3. That's all. That is why green dots are larger, regular, and few. So that's how you can remember this immunofluorescence, right? They are larger, regular, and few. Clear? So now you understood this is the nucleolar pattern. So where you will see the nucleolar pattern, that was the question in the AIIMS exam. That was the question where you will see. So remember, it will be seen in both scleroderma and Sjogren's syndrome, because both clinical feature were given in the exam and examiner had asked where you will see them commonly, right? Where you will see them commonly, where you will see the in this nucleolar pattern of immunofluorescence. That was the simple, not image based question, simple question, where you will see in this patient what will be the finding, right? Subcutaneous fibrosis and calcification or keratoconjunctivitis sicca. Now understood. So this point we must remember that when we are talking about the scleroderma versus Sjogren's syndrome, nucleolar pattern is most commonly seen in the scleroderma, right? Nucleolar pattern is most commonly seen in scleroderma. No, Prashant, no, it's not Sjogren's syndrome. They are most commonly seen in the scleroderma, right? So now you understood these 5 immunofluorescence patterns. That is what I wanted to teach you. right? So I just recall you, I will remind you so that you can remember, because it's not easy topic, right? So first of all, you can see there is a rim, just few fast recall, rim pattern, right? So rim pattern will be double standard DNA, peripheral area will be having bright immunofluorescence, right? Then we are seeing the diffuse pattern, that entire nucleus is having diffuse homogeneous immunofluorescence, bright green color. Then we are seeing the speckled pattern. Speckled means background is green and dark spots are present. Speckled pattern. Third is the centromeric. What is centromeric? Background is dark and numerous small irregular green dots. Centromeric, centromere corresponding, right? Nucleolar, the fifth one, what will be the background? Background will be dark and you will see only few large, well-defined, regular, immunofluorescence pattern. That is the nucleolar pattern, which is commonly seen in this scleroderma, right? So I hope you all understood this. All 5 immunofluorescence pattern, definitely you are going to get some question in your exam. Now, the last slide is, can you identify this picture? Can you identify this picture which has been taken from the SLE patient peripheral blood? What we are seeing? A cell. When it is covering nucleus, no problem. When a cell membrane is covering nucleus, there is no problem, right? But what happens in the SLE patient? Membrane will be damaged and nucleus will be exposed. And nuclear chromatin is granular chromatin. Remember, they are granular chromatin. If you see the normal nuclei, you will see the granular chromatin, right? So when nucleus is exposed, because of the SLE patient, there is a damage of the membrane, right? So when there is a damage of the membrane, what will happen? You will find anti-nuclear antibodies are formed against them, right? See this, anti-nuclear antibody cannot penetrate this membrane, but when the membrane has been damaged, this nucleus will be predisposed to the anti-nuclear antibody, and this anti-nuclear antibody will destroy them, right? Now after the destruction, now this nucleus will be converted into the damaged nuclear chromatin. So how it will be looking like? Damaged nuclear chromatin will be having homogeneous nuclear chromatin. So this is the homogeneous nuclear chromatin. So homogeneous nuclear chromatin is a damaged nuclear chromatin, right? It is a damaged nuclear chromatin. So this homogeneous damaged nuclear chromatin, can you tell me the name of this structure? Can you tell me the name of this homogeneous damaged nuclear chromatin? What is this called as? This is called as LE body. Remember, nucleus is called as LE body, or also known as hematoxylin body. So LE body or hematoxylin body, these are the damaged nuclear chromatin. So now you understood what is LE body. LE body is the homogeneous damaged nuclear chromatin because of the anti-nuclear antibodies, right? Now when they are coming into the peripheral blood, so this is the scenario. Now they are coming into the peripheral blood. When they are going through the peripheral blood, what will happen? Phagocytic cells. It can be neutrophil, it can be macrophage, anything, right? So phagocytic cell, this is the phagocytic cell, and I will show you the normal nucleus of the phagocytic cell, which is the granular. So granular nuclear chromatin, it is the normal nucleus, right? So what is happening? What is going to happen? Now this phagocytic cell is going to engulf this nucleus, which has been damaged, means this LE body. The LE body has been engulfed by them. Right? So this is the LE body. LE body has been engulfed by them. So this entire cell, this entire phagocytic cell, I'll just make it. This entire thing is called as LE cell. Now you understood. So this will be called as LE cell. Right? So what is LE cell? LE cell is a phagocytic cell consisting of LE body. Now you understood. So phagocytic cell along with the LE body is called as LE cell. So this is the same thing. You can see these are the neutrophilic nuclei. neutrophilic nuclei, right? And in this neutrophilic nuclei, can you see this? This is the nucleus, and now you can notice there is a homogeneous nuclear chromatin. So this is the LE body. In simple word, I will say that this is the LE body, right? This is the LE body, which has been engulfed by a phagocytic cell, a neutrophil, and this entire structure is called as LE cell. So now understood. So LE body, LE cell, these are very important thing which examiner had asked in 2016-17 All India exam. So what is LE body? LE body is the nucleus which has damaged homogeneous nuclear chromatin. Why? What is the LE cell? LE cell is a phagocytic cell which has engulfed the damaged nuclear chromatin, right? So these are the important thing which I wanted to discuss about the SLE, right? So next session I will be announcing you soon, and we'll be discussing some other autoimmune disorder, right? And this session will be keep continuing like this, right? So the last point is which I wanted to tell you all, that nobody is perfect. Please remember this point. Why I'm saying? Because being a medico, because I know that we all are so perfectionist, and we will try to make a perfection in studying also, right? It's not possible. So please remember, adjust your life along with the flow of the studies, right? Or along with these shortcomings, whatever you are having. Please don't feel depressed if you're not able to, because somebody will be very fast learner, right? And definitely Imran, I will be definitely continuing, and somebody are very slow learner. People are fast readers, slow reader, and we often compare with each other, right? We often compare with each other, and this spoils our entire, momentum, mood, preparation, and morale. Everything will be spoiled. So please remember, everybody is having unique finding. If you are a slow learner, definitely you will be remembering for the long time, right? I'm telling you, you have to search about your positive. That is what I wanted to say, that always look for the positive areas in your own character. Do not look for the negative thing. People are there to look for negative in yourself, right? Why to search by yourself, right? So please do not compare with anybody. You are your own hero, and you have to find out your heroics, right? So remember that point. You have to find out your heroics, and remember, nobody is perfect. And please remember, perfection is not a very good thing, right? Even God was not perfect. So please remember this thing, and always stay strong. And that is why I'm saying that when you are staying strong and not giving up, see, then you will be, if you are perfect, you just imagine you are perfect in everything. After 1 year, you will feel boring in your life, right? Then you will be going for depression. Why? I'm so perfect. So that's what I wanted to say, that improvement, why God has created like this, why nature has given like this, because he wanted us to improve every moment, so that we will be always striving for the perfection. But we should not be obsessed that we should become sick, right? Don't become sick for your, for getting perfection. The way you are studying is very good. Are you getting selection? Are you not getting selection? Does not matter. What matters? Your hard work. And hard work will give you a good result, not today, maybe after some day, maybe after some years, right? So please remember these points, and that's how I wanted to guide you all, right? And keep in touch. And now Unacademy, we will be taking the lecture, and we will be regularly coming for the Unacademy, and short topics we'll be discussing like this, right? Thank you so much to all of you, and my best wishes to all of you.